But before I get onto that, I just want to throw a few grenades into the room, okay? And sort of Fargal has sort of intimated about some of the, what I think are major problems we have in palliative care, palliative medicine. So my second ever job in palliative care was at St Christopher's Hospice in Sydenham, South London. And actually, I'm so old that Dame Cecily Saunders was still alive at that stage, and she was called the chairman of St Christopher's, and she used to come in every day, and she ruled the roost. I remember they redecorated some of the wards. They got an interior designer to come in and you come up with the colour scheme, because for those of you who've been to St Christopher's, it's a bit dark and dingy in places. There's a lot of wood there that was varnished and whatever, and they stripped that down and put nice bright, nice pastel colours. After it was finished, she made them change it back to the way it was. But Cecily is known for lots of different things, but I think the thing that she's not so well known for is the fact that she was determined that the clinical practice at St Christopher's would be driven by research. And St Christopher's, when it was built, they put in a post-mortem room in the basement so that it could undertake post-mortems on patients who died at St Christopher's, so they could have a better understanding of the pathophysiology of certain conditions, so that they could come up with some treatment strategies. And the classic example of that is malignant bowel obstruction. And Cecily Saunders was instrumental in bringing leading researchers of the time, obviously not in palliative care, to St Christopher's to do research. So bringing people like Robert Twycross to St Christopher's to do research on analgesics, bringing people like Colin Murray Parkes, psychiatrist, to St Christopher's to do research on bereavement, John Hinton, another psychiatrist, to do groundbreaking research on anxiety and depression in patients with advanced disease. So there was a huge focus on research. The problem is that we've lost our way, because now most of what we do is based on what they did at St Christopher's in the early 1970s. Research stopped at St Christopher's essentially. Everybody went to St Christopher's to learn about it, and the care is good there, was good there. And so it just got reproduced, and the research aspect got lost along the way. And actually, if you look at the evidence, very little of what we do today is evidence-based. This is the evidence-based pyramid. There are some things that you can guarantee when you look at palliative care research. If somebody does a Cochrane review, the conclusions are always exactly the same. There's no evidence, we need to do more research. But one of the problems that we've got is we don't know that what we're doing is not evidence-based. We assume, as Fargal said, we've been doing this for 20, 30, 40, 50 years, and we know it works. Well, we might be providing really good care, but is it the best care? Okay? The other thing that's really important is it's not just about randomized controlled trials. Okay? We need to remember what we were taught at medical school, nursing school, pharmacy school, wherever. Basic physiology. Yes, your physiology changes when you're dying, okay, but you're still a human being. Pharmacology. If drugs work in a particular way, or you need to give them in a particular way in a fit patient, then the principles still apply to a sick patient. You might have to tweak things, but you just don't start from scratch. And I'll come back to physiology when I'm talking about the Chelsea trial. One of my big bugbears, and I know that the PCRN with Marie Curie are going to look at priorities for research, is that since the original documents were produced, the funding bodies have insisted that they will only fund things that are on the priority list. And I'm interested in hydration at the end of life. That doesn't come in the top 10. It sneaks in at about number 68 or something on the top 80 list of priorities for research. And yet, in clinical practice, this is, particularly when you work in a hospital or on an inpatient palliative care unit, this is the thing over the years that has constantly caused disputes between families and clinicians. But it doesn't get on the list. And so one of the things I would say is when whoever is looking at these priorities, first of all, you need to look at the methodology. So I looked at who was involved in developing this set of guidelines. Only 4% of the people involved were clinical researchers. You can't set up research priorities without talking to the people who do the research, just like you can't come up with priorities without talking to patients and carers. It's a nonsense, because you can come up with a long list of things they want us to do, but if we're not interested or we can't do it, then it's meaningless. And we do have a lot of data actually from the population. If you're looking at end-of-life care, and I know palliative care is much more than end-of-life care, we do have a lot of data about what patients who are at the end of life, what their priorities are. And their number one priority is symptom control. Their number one priority in terms of good death is symptom control. There are lots of other things, okay? But for instance, place of death is irrelevant, relatively irrelevant. Yes, if you ask them, most people would say, if possible, I'd like to die at home. But what I want before that is I want my symptoms controlled. I don't want to be a burden to my family. I want to get my affairs in order. Okay, so I'm going to move on now to clinically assisted hydration. So this article was published a year before I started in palliative care. So Gillian Craig, as you can see there, was a consultant geriatrician, and she wrote in the Journal of Medical Ethics an article about what was happening in palliative care and her concerns about what was happening in palliative care, particularly around sedation and the lack of hydration. And she was questioning whether the traditional view model of not providing fluids at the end of life in hospices, but using sedative drugs was actually ethical or not. Now, as you can imagine, that caused a lot of consternation, lots of letters and replies from palliative care, including the group of consultants from St Christopher's Hospice. And this is part of their reply. So this is from 1995, okay? So the decision-making process should be based on a knowledge of the risks and benefits of giving or withholding treatments. But then they go on to say, you shouldn't do it. You shouldn't give fluids, okay? But there is, or there was, no evidence at that time to do it. But that was accepted practice, and still is. And then moving forward a little while, so I'm sure you're all aware about I'm not sure what the right word is, the debacle around the Liverpool care pathway. And one of the main issues around the Liverpool care pathway was the issue of hydration. I mean, there were lots of things, but it was around sedation, lack of hydration, etc. And again, as you're all very well aware, Baroness Neuberger undertook a review, and as a result of the review, the Liverpool care pathway was removed from clinical practice in the UK, although it is still used in other parts of the world. And there were two aspects to the Liverpool care pathway. There was the main investigation, if you like, where Baroness Neuberger and colleagues took evidence from various people, a lot of evidence from carers of people who died on the elliptical care pathway. And parallel to that, they did a review of the literature. And again, I'm not sure how many people in palliative care actually have read the Neuberger review. I mean, we all know what the outcome was, but it's quite stark, some of the things that Neuberger says. So I think their default was, okay, that we need to support patients with hydration and nutrition. You could argue what that actually means, but it's the bottom line, okay? If you don't give people fluids, then over a couple of days, the patient will die of dehydration, okay? And for many of the patients who were put on the elliptical care pathway, and many of the cases that were discussed at the Neuberger review, it was felt that the patients died from dehydration and or the use of sedative drugs prematurely, as opposed to whatever was their underlying condition. Having said that, the parallel document pointed out that there wasn't very much in the way of evidence. So, there's been this ongoing controversy, this ongoing disparity between what happens in hospitals and what happens in hospices. If you're in hospital and you're dying, you invariably will, if you're not drinking, not maintaining your hydration, will be given fluids. If you're in a hospice, it's incredibly unusual unless you have a specific problem like, for instance, you've got hypercalcemia or you're opioid toxic. So I mentioned about physiology, okay? So we are constantly losing fluids, okay? Some of us more than others at the moment. And so we constantly need to replace that fluid. So a typical person, needs to take in 2.5 liters of fluid a day to maintain hydration. Okay? And you can see where the losses are. Now, I appreciate in our group of patients, okay, that's probably not correct, but our patients still breathe, so they're still losing fluid through respiration. Our patients still sweat, and if they've got a fever, for instance, then that loss will increase. Most of our patients are still peeing a bit, okay? So they're losing fluids that way. Most of our patients are still having their bowels open. They're losing fluid. It might not be 2.5 liters a day, but they are losing fluids. And if they're not replacing it, then they will get dehydrated very quickly. Okay, so the evidence for clinically assisted hydration. So Cochrane recently, or this group recently updated the Cochrane review. And this is their conclusion. So as I said, palliative care Cochrane reviews always say the same thing, okay? There's no evidence, so you have to make it up on the spot. This is a terrible Cochrane review. It's so flawed in so many ways. There is a rebuttal to this review if you go on the Cochrane website. And I'll tell you why it's flawed, because they didn't point out any of these things. Okay? And that's the problem with Cochrane reviews. People just read the abstract, the conclusions. So if you read the abstract and your preference is not to give fluids at the end of life, then the abstract reinforces that view because there's no evidence that fluids do any good. Okay, there are 4 randomized controlled trials in the literature. To me, that is absolutely shocking. One of the biggest issues in clinical practice, and there have only ever been 4 studies. You can see the number of patients in all of these studies. Okay? I mean, what other, and this is not just, this is in the whole literature. So this is everybody dying, okay? This is not just people dying in hospices or, under palliative care teams. This is the whole literature, okay? Medicine, surgery, geriatrics, whatever you want. Pediatrics, there's no data in pediatrics. Okay, so you can see the small numbers. The other thing is all of these, certainly the two in the middle, the Barrera publications that everybody quotes, oh, Barrera did a big study, it didn't show any benefit. They were underpowered studies, okay? But more importantly, in those top 3 studies, they only included people who were dehydrated, and the treatment was 1 liter of fluid a day. So even if the patients were hydrated when they went into the study, 1 liter a day was probably going to not cover their losses. But these people were dehydrated. So if you, and the diagnosis of dehydration was based on clinical findings. So the clinical findings of mild dehydration, as you can see there, occur when the person, this is a 70 kilogram man, has lost 2 to 3.5 liters of fluid. So the patients who went into these studies were down 2 liters of fluid. They were continuing to lose maybe 1 liter a day, and the teams were putting in 1 liter a day. Is it any wonder there was no difference between the 2 groups? Because they weren't treating it. That's a bit like taking a patient who's got cancer pain and showing them the bottle of Oromorph and then putting it back in the cupboard. It's not a proper treatment. So apart from the Chelsea 1 study, which was a study at the bottom, all of the data out there is completely meaningless. But normal physiology is not meaningless. We have to understand that if patients don't drink, if I locked you in a cupboard and came back in 5 days, you'd be dead. Okay? You'd die of dehydration. It's the same for our patients. Okay? Now, if you're comfortable with that, that's fine. Okay? But you need to own that fact. Clinicians need to own that fact. So this is some nice guidance about how much fluid you need to maintain hydration. This is in the hospitalized patients. I appreciate that. Okay? But it's the same principle. It's based on what the losses are. Okay? So the 1 liter a day, even if the patient was well hydrated, is the correct amount of fluid for a 40 kilogram man, woman. Okay, so when you put up 1 liter of fluid over 24 hours for your patients, okay, you just need to think about what are you doing? Are you trying to treat dehydration? Because if you are, you're not. Are you trying to maintain hydration? You may or may not be, depending on the weight of the patient. Or are you just pretending because you don't want to have the argument with the patient, the relatives, or whatever? Okay? Dose is important. Right. Okay. So I've been interested in this for a long time and have tried to do research on this for at least 10 years, probably more than 10 years. And so, you know, to change practice, you're going to have to do a randomized controlled trial. Okay? And you can see that there have only been 3 previous randomized controlled trials. And the first study, we don't have any idea about what the sample size was or what, but you know, they just reported that they recruited a certain number of people. The other 2 studies, they didn't recruit the number of patients they set out to recruit. And the second Barrera study was stopped after 4 years. They only recruited 120 patients over multiple sites within Texas, and after 4 years, they stopped the study because they ran out of money. Okay? So, first of all, if you do a randomized controlled trial, okay, it's expensive. Okay? There is no way an individual researcher, okay, unless they won the lottery, can do a randomized controlled trial on their own of an intervention like this. The other thing is you need to think about, okay, people have tried to do straightforward randomized controlled trials in our patients before, and they have failed. Why have they failed? Has anybody done a randomized controlled trial in our group of patients and succeeded. And how did they do that? You have to think about the population. These are people in the last days of life, okay? Most of them are not going to be able to give informed consent. So how do you get around that? Okay, what are the most important endpoints and how do you assess it? If the patient can't complete a questionnaire, how do you assess whether the fluids are working or not? And it is clear that you need multiple sites. You can't do this at one site, and you should never do any research at one site in any case, at the risk of bias. And the other big issue is clinician resistance, okay? And I'm going to be even more controversial here. Nurses in particular, and nurses of a certain generation, and it's not even gatekeeping, it's we're not doing that research on this unit, okay? Because we know, because we've been working in palliative care for 20, 30 years, and you just don't do it. And you say, well, why don't you do it? Because you don't. Because if you do, all these terrible things will happen to the patients. And you go, well, how do you know that? Look, Moses came down from the mountain, he had his stone tablets, he had the 10 Commandments, and on the back it said, do not give fluids to patients at the end of life. Okay, but you can do it. And we spent a long time. The first time we put in a grant application to Marie Curie, we were going to do a straightforward randomized control trial. Okay, and we didn't get any funding. Mind you, we've never got funding from Marie Curie. We got a lot of support, but we've never got any funding from them. So we came up with this. First of all, we need to do a feasibility study. We managed to, before you do a massive study, and I'll talk to you about the Chelsea 2 study, you've got to have a proof of concept study, feasibility study. So we came up with a cluster randomized design. So in a cluster randomized trial, you don't randomize the individual patients to the treatment, you randomize the unit, okay? So in this trial, okay, Hospice A is randomized to fluids. That means fluids is the standard of care in Hospice A. That means, unless it's a contraindication, everybody who's eligible gets fluid in Hospice A, whether or not they go into the study or not. And the ethics committee were really clear about that. Okay, you couldn't give an intervention in a unit unless there was the option to have it outside of the clinical trial. We had a variable consent process, and this was on the basis of legislation in the UK, and I'll show you that in a minute. And we made the study, we developed the study in such a way that it wasn't going to interfere with normal care, and it wasn't going to be burdensome on the patients, their carers, or the nursing staff. Okay, and so Chelsea 1 study, feasibility study. So because of the feasibility study, we're not particularly interested in clinical outcomes, although we measured them. So we said we wanted to recruit 200 patients in 1 year, which was bigger than any previous study. Okay, I don't know why we chose that number. As in, like, looking back, just thinking, well, you had a good chance of not meeting that. We had 12 units, mixture of hospices and cancer centres in the UK, mainly hospices. And what we wanted to make sure is that the majority of the participants completed the study, and the study lasted for a maximum of 14 days. So the end of the study was when the patient either died or survived for 14 days. These are all patients thought to be in the last week of life. That the nursing staff completed the observation charts, and that was just looking at whether, we just asked them, has the patient got pain, agitation, et cetera, and that less than 50% of patients who were starting fluids, the fluids had to be stopped because of adverse events. But what we also did was we did a process evaluation. So we asked the PIs on a monthly basis for feedback, formal feedback about how the trial was going. And halfway through the trial, we ran focus groups of the clinical team So mixture of doctors, but predominantly nurses who were working on the ward rather than part of the research team about their experiences. And the other thing is site monitoring, and not to check up on them, but to provide support. Very important, particularly with research-naive units. Okay, how am I doing for time? Is that clock right? Probably 5 minutes, so 6 minutes. Okay, that means 12. Okay, so these are the interventions, not important. Okay, this is the consent mechanism, okay? So you can't pre-consent patients, okay? At least you can't in the UK. So, and also in the UK, carers can't consent to patients going into the study. But what they can do is they can not provide consent, but agree for the patient to go in, to sign a document that they felt that the patient would be happy to go into the study. So those are personal consultees. So if we could, we asked the patient, but it was last week of life, so the majority of patients couldn't give consent. So then we would go to the next of kin and say, this is a study, would you be happy for the person to go into the study? The care is exactly the same. The only difference is that the data that we collect will be sent off to the researchers. And then if there wasn't a personal consultee, a relative, then each unit has something called a study guardian, a nominated consultee. So this was usually a senior clinician, usually a nurse who was separate from the ward. So it would be a nurse manager, separate from the ward and certainly separate from the research team, who could give, again, agreement for the patient to go in. That person, actually, the nominated consultant was not the study guardian, because the study guardian was somebody else who could potentially stop the study in the unit. But there was a separate person, senior clinician, who would give approval for the patient to go into the study. Anyway, long story short, okay, we reached all of our endpoints. Hooray, hooray. Okay. Out of the 200 patients, only 16 were able to consent to go into the study. Okay? So we thought, great, we've done it. And we got funding from RFPB, Research for Patient Benefit, which is part of the NIHR, which is the research arm of the NHS. And we were told, well, if your feasibility study is positive, you will get funding for the main study from the HTA. So we applied to the HTA and they said no. Right. So then we applied to Marie Curie again. And they said, yes, great study, yeah, but you're going to need £1 million. And we don't have £1 million. And we said, don't worry, just give us what you can, because we'll make the money up from elsewhere. And they said, no, we can't do that. So then we applied to Horizon Europe. And we didn't get the money there. And then I thought, right, that's it, giving up. Okay, I've had multiple goes at trying to get funding for this study, sod it. Okay, I've got to get on with my life. So with about a week to go to the deadline for HTA, again, I resubmitted it. And I don't know why. And then we got glowing references from everybody. Amazing, we have to fund this, it's great. PPI referees thought it was amazing, the academic referees thought it was amazing. And I was just thinking, well, we sent in exactly the same thing like, a year ago, and you said it was rubbish. So, so that's the other thing, okay, don't be put off if you don't get funding the first time. Okay, so we did get funding, okay, for the second study, Chelsea 2, okay? So this is funded by the HTA, research arm of NHS. And importantly, it's adopted onto what's called the CRN portfolio, a clinical research network portfolio. That means that all of those hospices, okay, can access research nurse and other research support from the networks that are set up in the different regions throughout the UK. And that has made a huge difference. So you can get experienced researchers going into hospices to support the hospice staff there. So essentially the study is exactly the same, but we're recruiting 1,600 patients from 80 sites. Of those 80 sites, about 70 are hospices. Most of those 70 hospices have never done research before, or they'll have had people who've done masters and things like that, but they'll never have done an interventional study like this. As part of the study, we had to do an internal pilot to again convince the NIHR that it was worth spending £1.14 million on this study. So we tweaked, based on the feedback from the process evaluation, we've tweaked a few things based on some of the feedback from the reviewers. We tweaked a few things, but essentially it's the same study. This was the internal pilot, so we agreed that within a year we would get 40 of the 80 sites open, and that we would recruit over 600 patients. So we have just passed the 1 year. So the first year anniversary of the study was the 8th of November this year. As you can see, we've opened 76 sites. We now have opened 79 sites. And we recruited, 8th of November, 645 patients. We've now, as of Tuesday, what day is today? Thursday, recruited 729 patients. So we've recruited in this one study nearly 3 times as many, no, that's not right, at least twice as many patients in this one study as have ever been entered into a randomized controlled trial of fluids at the end of life. I'm going to skip over that. So there are lots of unanswered questions in palliative care. And research is challenging in palliative care. But we've had a bit of a nihilistic, which is a bit of a attitude to research, which is quite interesting, seeing as we're an end-of-life care specialty. It's too difficult to do. The barriers are too great. There are barriers, but you just have to overcome them. You just have to adapt your methodology to the patient population that you've got. And as part of both the Chelsea, as part of the Chelsea 2 study, we have got a bereaved carers survey going on, a postal survey, and aligned to that, a qualitative study looking at bereaved carers' views about end-of-life care research and also their experiences. And so far, we have had no negative feedback from bereaved carers about the study. A lot of them have fed back to us and to the sites that actually they find it a very positive experience. And for the patients, it was a positive experience as well. And this is something I hear a lot. People feel even if they're not going to get any benefit out of it, they're giving something back, and they want to do that. So we can do research in this group of patients. We can do good research. We can change practice. One of the results, and it's, you have to take it with a pinch of salt from the Chelsea 1 study, is there was an improvement in survival in the group who received fluids. Now, that might not be shown in the main study. Improvement in survival was about 2 days. Now, you could argue, okay, does that matter? Well, if you're waiting for your son, daughter to come back from Australia, then 2 days may be really important. If you're rolling around in agony, then yeah, 2 days is not great. But it's not up for us to decide whether that's appropriate. It's up for our patients. But what we need is for them to make informed decisions, is for us to actually know what we're talking about. Not just say, I don't think you should, or I don't think it makes a difference to X, Y, and Z. Let's have the data, and then let's make the patients make the decisions, or the carers make the decisions. And I just want to echo something that Fargal may not have said, but implied. Okay, yeah, we all give great care. okay? But good enough is not good enough. We should be given the best care. And the only way we're going to know about what best care is by actually doing the research and finding out. So thank you very much.